She came in saying she couldn't focus. She was forgetting things. She felt like she was falling apart. She'd been a high functioning professional her whole life. And now she couldn't even finish a thought. Her doctor told her it was stress. Her therapist increased her sessions, and someone eventually suggested ADHD. She was 44 years old. She got the diagnosis, started medications, and it didn't really help because what looked like ADHD wasn't ADHD. It was perimenopause doing something very specific to her brain, and nobody caught it because nobody asked the right questions. Today, I want to help you ask the right questions so your clients don't end up like her. I'm Heidi Hill. I'm a licensed clinical social worker and addiction therapist with 20 years of experience across crisis work, clinical leadership, and behavioral health. My whole platform is built around one question. Is it medical or is it mental? Because the answer is often both. And sometimes what looks like a mental health condition is actually the body sending a signal that nobody's learned to read yet. Today, we're going to talk about perimenopause and ADHD, specifically how to tell the difference between the two, because they look identical in your office and getting it wrong has real consequences for your client. Let's start with the basics. Perimenopause is the years before a woman's period fully stops. It usually starts in the mid-40s, but can begin as early as 35. During this time, estrogen levels don't just drop, they swing up and down in unpredictability, sometimes dramatically within the same week. Here's why this matters for the brain. Estrogen is not just a reproductive hormone, it also helps the brain make and use dopamine and serotonin. Think of those like the brain's focus and mood fuel. When estrogen swings, the fuel supply swings with it. So a woman who was managing just fine last year may suddenly feel like she can't concentrate, remember simple things, control her emotions, and she can't keep up with her own life. Not because something is wrong with her mentally, but because her brain chemistry is being disrupted by hormonal changes happening in the body. This is the medical event showing up as a mental health symptom in our clinics. And here's the problem. Those symptoms, poor focus, memory gap, emotion swings, feeling scattered and overwhelmed, look almost identical to ADHD. So the question we need to be asking isn't just, does she have ADHD? The question is, did she always have ADHD, or is perimenopause creating a picture that looks like it? The distinction matters more than most clinicians realize. Let's talk about what the research actually shows, because there's a lot of noise on this topic, and I want to give you something clinically useful. Research is clear that perimenopause can do two very different things when it comes to ADHD. The first thing, it makes existing ADHD significantly worse. If a woman already has ADHD, the hormonal changes of perimenopause can make her symptoms feel like they're tripled overnight. One large survey over 1,500 women with ADHD found that 94% said their symptoms got worse during perimenopause. 94%. And more than half said perimenopause was the hardest period of their entire lives when it came to managing ADHD. Harder than childhood and harder than their 20s and 30s. The second thing perimenopause can reveal, ADHD that was never diagnosed. Some women have had ADHD their whole lives, but they were smart, they were built systems, and they pushed through. Then perimenopause hits, estrogen drops, and the coping tools they built over decades stop working. They land in your office. And research shows that 43% of women are first diagnosed with ADHD between the ages of 41 and 50. But here's the clinical question we have to sit with. The DSM-5 requires that ADHD symptoms were present before age 12. That is a diagnostic requirement. So a true onset of ADHD at 45 is not possible under our current criteria, which means when a 45-year-old woman presents with what looks like ADHD, we have two possibilities in front of us. One, she had ADHD her whole life and perimenopause pulled the curtain back on it. Two, perimenopause is mimicking ADHD, creating symptoms that look identical but have a completely different cause. And here's why this matters. Practically, the path forward is different depending on what one it is. This is the part I really want you to take into your office this week. If perimenopause is revealing long undiagnosed ADHD, you'll usually find a history there. When you ask the right questions, something comes up. She struggled in school, but was told she was not just applying herself. She's always been disorganized, but managed it with color-coded planners and reminders for her reminders. She's always felt a little scattered, but high-functioning enough that nobody ever flagged it. The symptoms existing before perimenopause. The perimenopause just made them impossible to manage anymore. If perimenopause is mimicking ADHD, the picture looks different. The symptoms appear more recently alongside other changes. Her period becomes irregular around this time. She starts waking up at 3 a.m. She notices mood shifts that came out of nowhere. Her focus problems didn't exist 5 years ago. There's no childhood history of attention struggles, even subtle ones. Here are 4 questions that can help you start to figure this out. Did you struggle with focus, organization, or finishing tasks as a child or teenager, even if it was never a diagnostic thing? If the answer is yes, that points towards long undiagnosed ADHD. If the answer is a firm no, that points toward perimenopause mimicking it. Question 2 is, did these symptoms appear around the same time as any physical changes, irregular periods, sleep disruption, hot flashes, mood swings? Timing matters. If the cognitive symptoms arrived alongside the physical ones, the hormonal piece is likely driving the picture. Question 3, do your symptoms stay present, consistent day to day, or do they seem to shift, better some weeks and worse others, for no clear reason? ADHD symptoms are generally consistent. Perimenopause symptoms often fluctuate because the hormones fluctuate. If she says some weeks I'm completely fine and then I fall apart, that's pointing toward hormonal disruption. Question 4, has anyone in your family been diagnosed with ADHD? ADHD has a strong genetic component. A family history adds weight to late identified ADHD possibilities. None of those questions give you a definitive answer on their own, but together they start to build a picture. And that picture should shape whether you're referring to a psychiatrist for ADHD evaluation or referring to a hormone doctor that specializes in treating perimenopause. Let me paint a picture. Your client is 46 years old. She came in a few months ago saying she felt overwhelmed, couldn't focus, was forgetting things at work. She's tearful sometimes. She says she feels like she's losing her mind. You've been working on stress management, maybe exploring anxiety, maybe ADHD's come up. But here's what she hasn't told you because nobody asked. Her period has been irregular for about a year. She's waking up in the middle of the night. Her mood can shift dramatically within the same day. She's been having heart palpitations her doctor said were probably stress, and she's been losing track of conversations and missing appointments. Now, does that sound like a purely mental health picture? Or does it sound like a woman in perimenopause whose brain is responding to a hormonal disruption that hasn't been connected to what she's bringing into the therapy office? This is it medical or the mental moment? And your job as clinicians isn't to diagnose the hormones. It's to recognize that when the picture in front of us might have a medical layer and make sure someone is looking at that layer. A warm referral to a perimenopause specialist, a note in the documentation about the timeline of symptoms, and a conversation with her about how hormones and brain chemistry connect. That is within our scope. That's a good clinical care. I want to plant a seed here, and I'm going to stay in my lane as a therapist, not as a prescriber. But here's something worth knowing. The brain chemistry disruption in perimenopause and the brain chemistry disruption in ADHD are related, but they are not the same thing. And treatments that target one don't necessarily fix the other. Remember, the women I told you about at the beginning, she got the ADHD diagnosis, she got the medication, and she still didn't feel better. That's not failure of willpower or the wrong therapy approach. That's what happens when the treatment doesn't match the actual problem. That's worth naming in the room with the clients. It's worth asking, has anybody talked to you about the hormonal piece? It's worth making sure your medical provider and her mental health provider are not working in separate silos. Integrated care isn't a luxury. For women in this section of life, it's often the difference between spinning in treatment that isn't working and actually getting better. I want to take a minute on why this happens so consistently. For decades, ADHD research was done almost entirely on boys. So the way ADHD shows up in women, quieter, more internal, and more I feel scattered and overwhelmed than I can't sit still, didn't fit the picture clinicians were trained to recognize. Women were missed. They compensated, they masked, and the medical system kept hormones and mental health in separate rooms with separate doctors who weren't talking to each other. So a woman seeing her OB for hormones and her therapist for mental health, and nobody puts the two together. This is the gap we can close, not by stepping outside our scope, but by asking better questions, seeing the full picture, and making sure the right referrals are happening. Remember, the women I introduced at the beginning, she got the ADHD diagnosis. She took the medication. She still couldn't function. What eventually helped her was a clinician who asked a different question. Not, do you have ADHD, but what else is happening in the body right now? Her hormones were evaluated. The picture became clearer. Her treatment changed. And she started actually getting better. The clinician didn't do anything outside their scope. They just asked one more question. That's what I want for you. And more importantly, that's what your clients are deserving. If this kind of content helps you think differently about the women you're working with, hit subscribe. I post here every week for clinicians. And if you want to go deeper, I have continuing education trainings built around this exact topic. The link's in the description. Go ask the better question.